I was so ravenously hungry and craving. And what my patients described was kind of that. So I could imagine them being, in a 300-pound or 250-pound body with a lot of excess adipose tissue, trying to lose weight and feeling that way just I was already really lean, but like they're feeling that way at a higher body fat. That's what made me go like, oh man, I think I missed the mark.
You are tuned into the Dr. Tina Show with Dr. Tina Moore. For more, visit drtyna.com. On this episode of the Dr. Tina Show, I'm so excited to bring on Dr. Spencer Nadolsky. Dr. Nadolsky is someone I've been following for a long time on Instagram. He's an obesity specialist. He's a lipidologist. He also is the owner and founder of Vineyard, which is an online direct care model. He specializes in GLP-1s, and we are going to have the obesity conversation that you all have been asking me for. I've been talking about these peptides for a long time outside of weight loss, outside of type 2 diabetes, although my message has been skewed over the past few years. I've been trying to talk about them in relation to all of the other benefits throughout the body that they may or may not have in the clinical data. That said, this is an important conversation to have. We need to talk about obesity as a disease, and I need folks to really understand what that means. And I can't think of a better person for the job than Dr. Nadolsky. So without further ado, let's jump in. Dr. Spencer Nadolsky, I'm so excited to have you on the Dr. Tina Show today. And we are going to talk all things obesity, GLP-1s. This is a conversation I've wanted to have because I've been trying to sing the praises of GLP-1 agonists outside of obesity and weight loss and type 2 diabetes, just more in a metabolic health, cardiovascular, neuroprotective way. And everybody's been begging me to bring on an obesity doctor and a specialist
Perfect.
like yourself. So here we are. Thank you for coming.
We're doing it.
Yes, I'm excited. So I've been following you for years, and I'm a huge fan of your work. And I see more often than not these days, you sort of playing pickleball with all the GLP-1 misinformation and nonsense that comes constantly into our inboxes. I don't even get into it. I just let you do it.
It's exhausting. It's exhausting, like a game of pickleball could be, I suppose.
Yeah. Yes. And then you have really created this awesome, innovative direct care platform called Vineyard. So we're going to talk about that too, because I think what you're doing is exciting. I think you and I agree on a lot of things. One is that these telemed companies, for the most part, and I have heard good feedback from a few of them for really uncomplicated cases, for people who really just needed a little something. But in the case of most people and most patients, especially those dealing with at least a moderate to more excessive amount of obesity and or type 2 diabetes, I think that docs or patients need a much better care system. And I see you talking about that online. Can you extrapolate on that a bit more?
Yeah. These medicines are amazing. I would call them miracle medicines, but there's never a free lunch. And you may be one of the people that do just fine on a little dose and go through your journey just fine, no issues. And that does happen. However, I would say it's not rare. It's still uncommon, but common enough to when you have hundreds of patients that you see some of these side effects, especially at the higher doses, that get brushed off by someone if they don't listen. For example, the one that I'm seeing more recently, and I've made some videos on, is anhedonia, just kind of feeling meh, blah. And it actually happened quickly in 2022 when Mounjaro came out. We were all using it off-label. Everybody's like, oh, how dare you use that drug off-label? I'm like, well, the SURMOUNT trial was out. It just wasn't available as Zepbound yet. It wasn't approved yet, but the phase 3 trial was out, so we were using it for obesity a lot. And people were feeling tired. And you see it with Wegovy too, the semaglutide, but tirzepatide, we were seeing it, and people were like, well, it's got to be from the calorie deficit. And that makes sense that people would feel tired from a calorie deficit. However, there were people that weren't losing any weight. They didn't feel like any appetite suppression, but they were feeling tired. And so it's kind of like, okay, if they're not losing weight, they're not in a calorie deficit, they don't even feel the appetite suppression, but they're feeling tired, it's probably something beyond the calorie deficit that's making people feel tired. And when you talk to them, is it like, do you just want to go to sleep tired? For some people it is, but what I'm seeing is just kind of like a lack of motivation. So before, they were going to the gym, they're trying to be healthy, doing all the physical activity stuff, and now all of a sudden they're just kind of like, I don't feel like eating, but I also don't feel like working out anymore. And that defeats the whole purpose. We're trying to get people healthier, So like, despite their adipose tissue or whatever, physical activity has many, I mean, I know you've talked about this all the time.
Yeah, we're going to get into that. We're going to talk about the strength training, because that's the other thing that we definitely jive on.
Yeah, physical activity is super important regardless of the number on the scale. So like that's like, okay, that started, I saw it so many times, and then I made a video recently about it, and then all of a sudden I got tons of messages from patients because they didn't report it. They didn't even know it was a thing, but some other people did when they come from other places, and their doctors or nurse practitioners or whoever was saying like, oh, I think you just have seasonal affective disorder. I think you just need to go see a therapist. And they're like, what are you talking about? I never have seasonal affective disorder. I usually love the winter. This doesn't make any sense. And I'm like, no, this is the medicine. You're on a high dose, and then you pull them back, and they go, oh, now I still have the suppression and appetite, but now I'm going back to the gym, and now all of a sudden, like a bunch of them are starting to break past their plateaus despite being on a lower dose. So a lot of that type of stuff that I see.
That's personalized medicine. Everyone's always like, what's the dose? I'm like, it totally depends on the individual in front of you, and so many variables and factors. And a little bit too much can be a lot too much. And it throws them into that, just the blahs, I call it. They don't want anything. Yep. All their dopamine pathways are just kind of like food's not that interesting. Dark chocolate's not that interesting. Maybe sex isn't that interesting. Nothing is interesting. And I think too, the other conversation is for people who show love through food, who show passion through food, that's how they find their community. That's how they spend their time, is through love of food. Foodies, we have a lot of them here in the Pacific Northwest, and you can dose them into losing that. And so I hear it from my girlfriends all the time. They're like, all the ones using it for vanity weight are no longer going out for drinks or food anymore. Their social lives are crumbling, and they're walking headlong into osteoporosis. And I'm like, God, what are you guys doing?
Yeah, if you're not enjoying life anymore, what's the point?
Yeah. And I think that that's a real issue. I heard some young gals talking about just complete lack and luster of libido. And these were women in their 30s. And I was like, I think that your dose is probably too high.
That's right. I see that not infrequently. I've actually surveyed on my Instagram and other places, thousands of people taking the survey. And it was like, some people noticed increases, but around I don't know if it was like a third to a half of people said, no, I noticed a decrease despite losing a lot of weight and they want to have that desire. And of course, their husbands are looking at them and going like, oh, God, you lost weight. I'm kind of getting interested. But now the wife doesn't feel, and I see it in guys too, though. I've seen a few where they're like, no, they're getting erections because their testosterone has increased, but their libido, their drive has decreased. And it's the motivation factor.
Yeah,
it is.
Yeah, they don't want to chase their dopamine dragons. And I've heard people say they stopped doom scrolling on social media. They broke the habit of online shopping. It's all the different types of dopamine dragons. But we don't want to dose people into oblivion. That's no fun. You shared a really interesting story the other day about a younger woman who you reduced her dose significantly.
Mm-hmm.
She was not losing weight, and then you reduced her dose, and she started losing weight and started feeling much better. And I think that story, if you want to share a little bit about that case, really.
Yeah. Woman in her mid-30s. She had been on 15 milligrams of tirzepatide, Zepbound, for multiple months and had plateaued completely for the past 3 or 4 months. And I was like, you know what? And she kind of described I don't feel like going to the gym anymore. And I was like, you know what? Let's pull back on your dose. When you look at the Surmount trials, if you've ever pulled them up on your podcast, but the 5 milligram tirzepatide is similar to the highest dose of semaglutide, Wegovy, the 2.4 milligrams. It looks around 15% or so percent total body weight loss. When you look at 10 milligrams versus 15 milligrams of tirzepatide, though, there's a very sliver difference of weight loss between the two. So that means that they're probably getting very similar appetite reduction, but between the 10 milligrams and 15 milligrams. Some people do better on that 15 milligrams, but like a lot of times you start going up from that 10 to 15 milligrams, you don't really see much of a difference. And if you don't see much of a difference with the weight, the only thing that can happen, I mean, it's kind of logical that you could potentially see more side effects. And so what we did, we brought her down to the 10 milligrams, and she felt so much better. She started going to the gym, broke through a plateau, lost 10 pounds, even though she'd been plateaued for months on the highest dose. And this doesn't break the laws of thermodynamics. People are like, oh, it's all calories in, calories out. Yeah, she didn't feel like moving anymore.
Right.
Because the drug was, and now I always talk about the drug facilitating behavior change. But once it gets past that point, and now all of a sudden the behavior change isn't occurring because their dopamine's so dampened down, that's not good either. So yeah, it was pretty cool. It was really interesting. I was like, please, can I share your story? And that's when I did. And then tons of people started messaging me going, I think that's me. And I'm like, holy cow, this might be a bigger problem than people understand.
I think it is. I think there's a sweet spot for each individual. And I think it depends on factors, at least and I know you've dealt with this a lot more in the obesity realm and probably with way more patients. But the factors that I see impacting it are, how active are they?
Mm-hmm.
What's that sweet spot where you can get appetite suppression but not crushing it, or more of appetite control. We just want appetite control. Not, I guess in some cases we would want some suppression, but generally speaking, I just want people to feel in control of what's happening with what they're choosing to put in their mouth. And then past that, you get into the blahs, and then they do stop moving, and so you lose you lose thermogenesis because they're just like this on the couch. You're not getting any of that NEAT. You're not getting any of the, even people who I really do believe that a lot of folks stay lean just because they're fidgeters. Like, I'm a fidgeter.
Yeah.
It keeps me, that's how I keep going. And when you lose that desire to get up and go and bustle around, and you can dose people into that place. And I think that that's probably happening. And I really, my biggest concern at this point is these medi spas and what the actual hell is going on there. And then a lot of the telemedicine companies, I think some of them again are trying to do a better job and really do care, but there's others that are just like fly by night. And then what I don't think people understand is they're giving kickbacks to influencers.
Yeah.
And so a
lot of money.
A lot of these influencers are using my name and putting my name as like a stamp of approval onto, and like giving out specific dosing. It's crazy. And whenever I see it, I message them and I'm like, take that down. Like, this has nothing to do with me. And this is the telemedicines companies, like the whole microdosing for weight loss conversation that was never intended. I never, ever intended for that.
You became famous for that.
But I was never trying to say that. You know what it was? It was every single time I went on a podcast, the host couldn't get away from the weight loss conversation.
Okay.
They just couldn't stop with the weight loss conversation. And you know how people are, they hear what they want to hear.
Yeah.
And so it got twisted into something that I never intended. I mean, sure, if you take someone like me who's sitting, right on the edge of menopause and they're metabolically optimized, they're lifting weights, they're eating sound, they're hitting their protein macros, they're doing their HRT, all the things. And there's a little fluff, a little insulin resistance, a little metabolic dysfunction. Yeah, it tends to melt off, but it's not a weight loss strategy. It's not there to get that like 5-10 pounds. And then the mainstream media ran with it, never bothered to interview me. And then all these doctors started to claim to be doing it.
Really? Oh, that's funny.
So what you have probably seen out there is never at all what I started talking about. It got twisted along the way. And I am glad that the conversation opened about a more personalized dosing strategy, which is really what I was trying to say is like, if you are going to use it for weight loss or type 2 diabetes, could we potentially start people at a dose that doesn't make them vomit profusely for 2 weeks while they adapt? Like, could we onboard more gently? That seems reasonable. Right?
Very reasonable. And honestly, it's needed sometimes. In other countries, they have clickable pens that you can do. Well, Ozempic actually has a clickable pen, and that's here in the United States. But Wegovy doesn't have it. Zepbound doesn't have it. Mounjaro doesn't have it. So you see a lot of people going to the compounding route, which is kind of going by the wayside now. But like in other countries, there are quick pens that you can do tirzepatide in between doses, and it really is needed. It's more for semaglutide's not as well tolerated, so it's nice to have that for semaglutide. But even tirzepatide, like if the starting dose is 2.5, and sometimes I'm like, I really wish I could do like a 1 milligram because like this person's like a high responder to this stuff. They're losing weight too quickly, even on the lowest dose. It would be nice to just go a little bit lower, even half of that. But you have to get the vials, and the vials are a single use vial, or you'd have to inject the pen into and make your own bacteriostatic vial yourself. Like
Right.
it's ridiculous. And then it starts getting a little bit potentially dangerous there. So yeah, it would be nice if, and that comes down to, and we can get into the corporate greed, the pharmaceutical greed, but they don't want people splitting them up, because otherwise we could just prescribe 15 milligrams of Zepbound or Mounjaro and just have them split up into the smaller doses and have it last longer. They don't want that.
It's so dumb because every other pharmaceutical on the planet, we can generally alter the dose to fit the patient.
Yes.
If we need to cut a tablet in half, that's how I've always understood compounding pharmacies, and what I've used them for was when the dose needed to be something different, or maybe they didn't want the dyes that were on the medication, or that there was filler, or there was corn additives, or whatever.
That's right.
So yeah, it's gotten way out of control. And anyway, just to my point earlier, my conversation that I was trying to have originally was like, hey, look at this. I originally was looking at it for the reduction in neuroinflammation and its potential for pain. And then I was looking at it for more of like a metabolic rehab, because sometimes you'll get patients like myself, they're in their early 50s, they're going through menopause. And as that transition is happening, they're lean. I mean, I have some patients with 6-pack abs. And all of a sudden, out of nowhere, even with HRT on board, we start to see insulin resistance. We start to see a little bit of the lipids starting to shift. We start to see some cardiovascular markers. And I'm sure it'll quiet down in 10 years when perimenopause is over or whatever. But in the interim, something is shifting, and you give them the tiniest little bit of GLP-1 and it calms it all down, and their labs get really beautiful. And that was something I was trying to talk about. And it didn't matter whose podcast I went on. I had some great hosts ask me some really great interview questions, but for the most part, Callie Means was making the rounds at the time.
Oh.
And he was blasting, I don't know what his agenda is on that, but he was blasting GLP-1s. And so everybody had to, and he had already made that podcast, visit prior to me. So they all had to ask me, what do you think about this? And what about obesity in children? And what about all these things? And I'm like,
classic.
This is not the conversation I came here to have. Like, bring on Spencer to talk about GLP-1s and obesity. I was trying to have a different convo. So anyway, it got very twisted. So that's why you're here today. Enough about me. So let's talk about life pre-GLP-1s as a practicing obesity specialist and life post.
Yeah. So I went to med school late 2000, so 2007. That's right when these drugs started coming out. Byetta was the first one, exenatide, but it was for type 2 diabetes. It wasn't on the radar to use these for weight loss. At the time, people were really focusing on basically phentermine. A noradrenergic sympathomimetic drug. It has amphetamine-like properties, but not addictive. A little bit of an upper. But yeah, noradrenergic. And that was like basically what people used. I started going early on to obesity medicine conferences, and there was some weird stuff that they were promoting. And, you got HCG and all sorts of stuff that people were trying to use HCG diets, but a lot of phentermine. And if people remember phentermine was one of the components in fen, but it was not the bad component. Fenfluramine was the one that caused heart valve issues. And so they took that one off the market, but kept phentermine around. It had been around since the 1950s. So once I got to residency, which was 2011, right in 2012, Qsymia was approved. And that is a combination of phentermine and topiramate. Topiramate works in GABA. They think that's part of why it works for appetite suppression. But think about different receptors, lower doses of each, so you get fewer side effects. The phentermine can cause people to have insomnia, dry mouth, heart palpitations. So you try to use lower doses and then add it to something else that has a little bit of a appetite suppression which is topiramate, doesn't work in the same pathway. So that was approved, and that was for chronic weight. And that got, the highest dose gets around 10% total body weight loss. So not bad, but side effects. The other one was, if you remember, lorcaserin with Belviq. It is actually similar to fenfluramine, but it had a different serotonergic receptor, more specific. Actually got taken off because of, we don't know why exactly, but some concerns for cancer. Very mild weight loss effect, though, around like 5 or something percent total body weight loss. There was Contrave that came out in 2014. Bupropion naltrexone combination, not that great, still out right now, 6%, maybe 5-6% total body weight loss. And when you think about like good diet and exercise, intensive coaching, you're going to get around 5 or 6% total body weight loss on average. People are like listening, going, "I lost 100 pounds." And it's like, yeah. Like I'm saying, on a population average, we're looking at that number. So Contrave or bupropion naltrexone wasn't that great. So it was very frustrating. In residency, I'm like, I'm going to be an obesity doctor. I'm trying to do my thing. And those are the drugs that I had. It was 2014. I believe it was Saxenda, liraglutide, if people remember Victoza. So liraglutide was the second GLP-1 receptor agonist that came out in like whatever it was, 2009 or something for type 2 diabetes. But 2014, they cranked the dose up to 3 milligrams. Now, liraglutide is a once daily injection. And that high dose liraglutide in 2014, they promoted as Saxenda, was around like 7 or 8% total body weight loss. So like, it's okay, but it's like a $1,200, $1,000 drug for more side effects, daily injections, and overall not that great amount of weight loss. So that was like we went from lifestyle, trying behavior with some high side effect drugs that some people responded to. And then you jump all the way from that to bariatric surgery that, do you get 30 to 40% or more total body weight loss? Pretty drastic. People are like, "Oh God, I got to get surgery." It's like, great. So that's why in 2021, when semaglutide, Wegovy was approved at that 15% total body weight loss, things changed so much. That's why everybody's like, it's a game changer. Because like we were really limited in how we helped people. It was like resources for intensive coaching. That takes a lot to get people. And then it's very frustrating because everybody says they know what they do. I mean, my patients aren't idiots. Some people are, some people are idiots. They don't know what to eat. I remember a patient, I was like, "Here, let's try to eat more protein, whatever." And they came back and they're like, "I don't know, I'm eating more protein, but I can't lose weight." And I was like, well, tell me what you're eating. And they're eating a bunch of spare ribs. And I'm not saying this person is idiot, but it was clear, even though I gave a list of the foods, like spare ribs, that was what they were eating for protein. And it was, along with a bunch of other things. But most people understand that, hey, I should probably eat more broccoli instead of French fries. Like, It's just very, like,
basics.
Just very, very, most people have that. And a lot of these people have been trying for their whole life. And so like for them to come to a weight loss doctor, specialist, obesity specialist, and me basically going, "Okay, here's what we need to do. I got these other drugs that maybe you're not going to tolerate, but like, let's really focus on these behaviors." They're like, "I already know these things." It was very frustrating from a doctor's standpoint, a clinician standpoint, and then also from a patient standpoint. It's like, so that's why they go and get the $300 a month detox from someone online or whatever that promises to rid them of their fat, and then they lose all their money doing that, and then it's just very frustrating. So that was what it looked like before these drugs.
Yeah, so complete game changer.
Yeah,
because these peptides put the onus of control back in the driver's seat. And they induce neuroplasticity. So while these people are making the good, healthy lifestyle changes, their brain is rewiring in real time as it happens. So they're laying down tracks of good behavior, if that's happening, if they're being managed correctly, which goes back to what we were saying earlier of like, get out of the med spas and get with somebody who actually knows what they're doing, because there's so much opportunity there in that time frame to have really wonderful lifestyle habits. And that's... And so my background was helping. I helped a lot of people lose weight. It was not the main focus of my practice. My practice was regenerative medicine, but I helped a lot of people lose weight. And they often, even with best intentions, they eventually would swing back and have substantial weight regain, even following the same dietary habits, right? Eventually their body would catch up. And so can we talk about that? The disease of obesity. I don't think my listeners or some of them really appreciate this for what it is. And I have to be honest, I did not appreciate it for what it was until recent years. But I come from a long line of obese folks. And I think Oprah said it in a way that made the most sense to me. She said, not everyone who's obese has the disease of obesity. And not everybody with the disease of obesity ends up being obese because of just really strict willpower. They sheer willpower through it. But I think that I think we're missing the mark for folks who really do have the disease. And I think that's what we're battling online. I think that's the stigma around these peptides. It has nothing to do with the peptide. People are just, you said it in a post, you said you just have obesity bias. And I was like, that's that's pretty much it.
And I don't even blame, I was just on another podcast. I don't even get mad at these people because I had it myself. Like I was a young wrestler, pretty jacked dude, and been like, why aren't these people just like eating better and exercising? Why? It seems like it's just they're lazy and gluttonous or something like that. It wasn't until, going through med school and then going to conferences, talking to very smart neurobiology experts and researchers and other obesity doctors, and then talking to patients and really seeing the pattern where I started to understand it. And actually, it was when I did a bodybuilding competition and brought my calories just to 20. I was trying to eat 2,200 calories, which is probably what most people would be like, that seems like a lot. I was starving on 2,200 calories. And I couldn't stop myself from eating Pringles and I started kind of having disordered eating. Like I couldn't stop. I was so ravenously hungry and craving. And what my patients described was kind of that. So I could imagine them being, in a 300-pound or 250-pound body with a lot of excess adipose tissue, trying to lose weight and feeling that way. Just that, I was already really lean, but like they're feeling that way at a higher body fat. That's what made me go like, oh man, I think I missed the mark. And so there's two different things, because there's people think of the disease in two different ways. The disease, the way the AMA kind of described it back in 2013, the criteria of like certain signs and symptoms, certain associated with morbidity, mortality, those types of things, like definition of a disease versus the pathophysiology of what drives it. So right now, there's the Lancet Commission just came out with their whole definition of obesity, and they tried to describe basically preclinical obesity. So basically people that don't have those sequelae or issues from their excess adipose tissue, they're healthy basically, other than just a lot of adipose tissue. Then they talk about clinical obesity, and that those are people with, say, like type 2 diabetes or prediabetes, hypertension, some issues arising from the excess adipose tissue. So that's how some people talk about the disease of obesity. But what I think you're getting at, and what I like to talk about, is that the pathophysiology of what drives that adipose gain. Why is it that some people, they just change their habits a little bit and lose the weight and never gain it back, versus other people, they try to lose the weight and their body fights them tooth and nail, and they essentially just cannot lose the weight or keep it off without some extra tool, despite their best efforts and all the amount of effort that they put into it. So it's that pathophysiology that I think is really what people need to understand, because otherwise they just think it's a choice.
Yes.
Like you just think they're just like, I don't understand. It's just a calorie deficit. Well, it's like, it can't be a disease. And it's like, whoa. I was like, what is choice? Even if it were a choice, that doesn't mean that this person doesn't have a disease. I always, for the bros out there, I'm always like, let's say if you knew that this woman out there had gonorrhea, let's make it really crude. and you choose to still have intercourse with her, and you get gonorrhea. Do you not have a disease because you chose that? No, that doesn't even make sense. You got to think of that logic.
Good point.
And then I always talk about, like, what about type 2 diabetes? We don't think of it that way. Do we say people choose to have type 2 diabetes? No. So the choice thing doesn't have anything to do with it. But going into the pathophysiology, though, it's like, how, if it truly, even if it, like, it's not a choice, though. It's not a choice, because, like, people would never choose to have obesity. And people are like, well, they're choosing the habits. They clearly chose an extra serving, an extra helping at dinner when they didn't have to. It's like, no, it's the underlying appetite dysregulation or derangement that's driving it. The biology drives the behavior. And of course the environment. So, like, Callie Means and all these other people will say, like, no, we don't need drugs. We need to change our environment. We do need to change the environment. The environment will help prevent the obesity from occurring in the first place. But once that obesity develops, their brain is changed.
Yes.
And
their genes are
about
changed. They're
Yeah.
changed at the genetic level. I don't know if you saw that study. I'm sure you did last week. Like actual genetic changes. I mean, it's like the train has left the station.
Yeah. I describe it as, like, think about the circuits in our brain, and the circuits in our brain control a lot of our processes in our body, one of them being appetite. In a normal brain, that's someone that doesn't have obesity or struggles with their appetite, all the circuits are working well. But think about, like, someone that struggles with their obesity and losing that weight and keeping it off. There's short circuits. They're frayed and fried. And that's why these GLP-1 medicines are so cool, because they seem to recircuit the brain in a way that, again, it's not necessarily permanent. It recircuits it as long as you're taking the medicines, but it hits the receptors to basically stop the short circuiting of the brain. So that's the pathophysiology of it's really related to appetite. And people are like, but it's just energy balance. I'm like, yeah, the appetite drives the energy balance.
Yeah.
And so that's the gist.
There's insulin resistance as a extra added variable. And I've seen people develop type 2 thin. Well, this happens a lot actually as people age. It's just inflammaging. I've seen patients that my mentor before me took care of, and then I inherited them when I took over his practice, and I took care of them for a long time. And I would watch them age into diabetes. Thin, rail thin individuals, people who worked on farms. Like, these were not people lacking, they weren't buff, but they were like farm strong. Like, they're built like my husband. My husband's just raily and strong AF. And I mean, the man can pick up trees, and it's
awesome.
It's crazy.
Awesome.
So that's how these guys were, and yet they would still develop diabetes. And so there's all kinds of variables. And then when getting back to the appetite, there's leptin and ghrelin, and are they producing enough? Or is their receptors hearing it? Is there resistance, like an insulin resistance? I mean, there's things we don't even understand that we're just only starting to understand. And I look at them all as playing together like an orchestra. And GLP-1 is an important part of that orchestra. And if it's not there, the leptin and ghrelin signaling get off, and the insulin signaling gets off, and everything. I don't know. It's frustrating when people say, "Oh, it's just eat less and move more." I'm like, yes, and there's everybody's an individual, and we're looking at a different. Maybe somebody's just stressed out beyond belief, and their chronic cortisol is destroying their metabolism. Who knows? I'm not there to judge. I'm trying to figure out what tools I need to bring on board to give them a leg up so they can start making, because like you said, most people are pretty smart and they just need a little help.
Yeah, I always like showing the other side of the coin. There are thin people that do not try to be thin. They're just thin. Are they choosing to be thin? No, they're just thin. They're eating crap. And people are like, yeah, but they can eat, they just must have a faster metabolism. Well, if you actually look at them, instead of eating 5 pieces or a whole piece of pizza, a whole pizza pie, they're maybe eating a slice or 2, and they're good. And they'll go and smoke their cigarettes and whatever. They're fine. And they'll drink some soda. It doesn't matter. They're not choosing to be thin. So I think when you start thinking about it in terms of, like, how biology works and how it drives our behavior. And of course, yes, the environment is super important, because the environment is what changed over the past however many decades. It's not, our biology didn't change, but the environment then changed our biology.
Yes.
once we gain the weight. And I think that's what people don't understand. And I don't think they just haven't been able to put themselves in those shoes. And again, the only reason that I kind of understand is because I did that bodybuilding thing and I was like, man, I was ravenous at just like a pretty high amount of calories.
Yeah. And the biology, the environment did change the biology, and it wasn't just the generation of the person struggling, like epigenetically.
Yeah.
And if you are in utero and your mother is insulin resistant and you are bathed, we have the data, you're bathing in insulin, you come out with a much higher propensity for insulin resistance, metabolic dysfunction, and obesity. Like you're pegged for it. So, and this didn't just happen in our generation. This has happened. It has been happening for decades, whatever the toxicity levels in the environment, everything, whatever the microplastics, we could go on and on. We now have tools to deal with the current situation. So why aren't we using them, and why are we vilifying them, and why are we making people feel bad for wanting to use them? That's what I don't get. It's like, it took us several generations to get into this mess, and we now have this miraculous tool to help people potentially get out of this mess. I don't know if you saw yesterday, you probably did, AON, that is it life insurance company? They were looking at, let me pull it up. This is really cool. GLP-1s can help employers lower medical costs in 2 years, a new study finds. AON researchers found that within 2 years, improved health outcomes for patients who were taking GLP-1 drugs lowers the growth rate of medical care costs. Initially, that first year, it was an added expense, but then over time, like significant drop off of all kinds of morbidity.
Yeah. So here's what they're going to claim. They have some data that shows people stay at a certain job for however many years. What these places don't want to do is go, all right, we'll put in all the amount of money only for the next insurance to benefit from that medicine. So these are the games these insurances play. If we can figure that out, I mean, I don't know. I have all sorts of different thoughts because some of me feels like, why don't we just make the drugs so cheap that like people just pay cash?
Yes.
And like, don't even worry about insurance. Like they can figure it out. I know they can.
Yes. That's where the PBMs come in. That's where the pharmacy benefits managers screw everything up, because Callie and RFK are over here saying it would bankrupt America if we cover this drug for obesity with Medicare. And Trump's over here saying we need to get the drug companies to bring the price down. And I'm in the middle like, hey, PBMs, you're actually the problem. Why does this drug cost, $100 or less in other countries in Europe?
Doesn't make any sense.
No.
I hate it. It makes me so mad. I'm like, oh, well, I guess we're all just going to fly to the UK just to get these drugs. Just so ridiculous.
Yeah, it's really, really messed up. And I do think that there's room for these to be incredibly helpful long-term and bring down morbidity and mortality. We are really we're in a pickle here in the US, and we've exported it out, but we are between the rates of obesity plus overweight. It's pretty high.
So because here's what I see in the future, and people have asked, like, could everybody be on these? I think it's possible. And again, I'm not advocating that everybody should be on these. What I'm saying though is like, imagine a world where we're getting so good at like precision medicine and being able to predict things. So like, sure, person that has the indication of obesity, we got to put them on it and help them lose the weight. But what if we see that person's child and they're starting to go in that trajectory towards that same diseased obesity state? You could then target that person, put a little low dose, and prevent the obesity from occurring in the first place and all the sequelae that comes with it, and ideally at a low price. So I do think. And the other thing is, you said, why not use this technology? It's the same thing. If like, is anybody using a horse and carriage? Sure, in like Pennsylvania and Amish country and things like that. But like, you're using your iPhone, or you're using a Telegram, we're using technology. Let's as long as it's safe, of course, that's what we got to make sure. But I like to embrace it as long as it's good. And, obviously we've been burned in the past, and you got to be careful there. But I say embrace it.
I say the same. And my argument to the folks who are so against it, like some of these big influencers who are just so against it, I know these folks are on compounded hormones.
They're on all sorts of stuff.
I know they're on other peptides. So I'm like, this is interesting. I could make a pretty sound argument that a 40-year-old woman who needs a compounded or even just a low dose of thyroid medication yes, give it to her. Fine. That's great for subclinical hypothyroidism. Like subclinical hypothyroidism untreated, we have data to show like significant increased risk for hyperlipidemia, heart attack. I mean, all kinds of problems. But that said, I could also say that that woman's me, right? When I was in my early 40s on it, my life of chronic stress, chronic undereating, chronic whatever I was doing in my teenage years, being a bad kid, not eating well, not taking good care of myself, I blew out. I blew out my immune system and I ended up with Hashimoto's. So it's like I could make a sound argument that most of the medications that people are on start out as a lifestyle issue.
Yeah.
Start out as a choice that they made a bad choice somewhere along the line and they ended up where they are now. And nobody says boo. They're fine. They take whatever they take to make themselves feel better. I am not judging. I don't care. Whatever anybody needs to take to feel better is fine by me. But yet this one particular medication, everybody has to have some moral compass with it.
It's weight bias. I think if people really they really have to think deeply, and it doesn't feel good to feel like, oh God, do I not like, fat people type of thing? It's a weight obesity bias. Like if you really dig deeper, like why not help them? I don't know. There's no reason not to.
Yeah. No, I get you. Okay, so let's spin this into a more positive note. Let's talk about strength training. I really am at the point where I don't think that unless, I know it takes some people time. I know it takes the folks that I've treated with true obesity on these, it takes them about 3 to 4 months before they really start feeling like they want to move, because sometimes they're just in such terrible pain and in such a bad spot that it's hard to get them going. But I really firmly believe that if you're not strength training regularly while you're taking GLP-1s, you just you shouldn't be on them. Like that's where I'm at.
So the way that I approach is basically, I strongly recommend, I have a program called LiftRx. I'm like anything. I don't care if it's 1 day a week. I don't care if it's 10, you start off at like 5 to 10 minutes once a week, please. And I will say most people like, they want to. And again, like you said, there's some people that just, the knee pain, they never felt like they could. They were just feeling miserable. But after you get them going, it takes some nudging. They start getting more physical activity, like, at least walking and things like that. But ideally, if they're losing a large amount of weight, it would be ideal to weight train. Now, I don't gatekeep because I'm like, I can't force anybody to lose weight. And I do think the clinical benefits of losing the adipose outweigh not losing the adipose if they're not going to strength train, but like strongly encourage, strongly push it, So it's, if I could, be very paternal and make sure everybody does everybody would be weight training at least 2-3 times a week, if not more, but 2-3 times a week. Yeah.
Yeah. And it's not just because we're trying to hold on to lean mass. There's lots of other benefits.
Yeah. So functionality, physical function, just living, activities of daily living, making sure that, hey, can you get up the stairs? Hey, maybe you got to pick up your bag of groceries and bring it up the stairs. All those types of things are so important. It goes back to the quality of life thing. And if you're not going to enjoy life, it's not worth it. I mean, at least in my opinion. I don't know. Maybe other people feel differently, but it's not fun to live a not fun life.
No, and especially when folks are dealing with extreme obesity and they're trapped in their homes and did you see that movie, The Whale, with
No,
Brendan
I need
Fraser?
to see it because it was supposed to be really good about obesity and everything.
Man, it's such a good movie. I just love Brendan Fraser and his story. He played Tarzan. I don't know how old you are, but
I watched that.
He was such a super babe to my generation. We were so crushed out on him. And then he did get quite heavy, and you could just see he's like, I think he's got some thyroid issues going on. But anyway, for him to play that role, and then, it was really compelling because it shows you the inside of life, which is he can't even get to the first floor. He's stuck in a second floor apartment until he dies, and so they have to pull him out. You know what I mean? And it's like, I don't think people realize how bad it can get for some folks. And I think there's there's such gray areas in medicine, and everybody wants it all to be so black and white and so simplistic. And that's just that most patients fall somewhere in the gray zone, right? And so
Yeah.
how do we get folks motivated to do the things they need to do, to work out, to lift the weights, to eat the right foods? Well, we have a tool. We have this awesome tool called GLP-1 receptor agonists that give people all of those things and a window of opportunity to hardwire those things in if they're given that full support spectrum. And
Yes.
I think the problem, though, is a lot of docs themselves are just super unhealthy, and they don't strength train. They don't know the value of it. When I was trying to talk about strength training over a decade ago, I would go to medical conferences and try to talk about it. I'd get heckled by MDs. There'd be these guys in the back, like, whatever. And they're, chronic cardio cyclist guys. And I was like, okay,
Yeah.
I'm sure I'm right about this. Well, I'm glad the data's caught up now. But I took a lot of shit back then.
Yeah, it's you'll still see it right now. Like, I'll get patients that their doctors will be like, no, you just need to go running. And they're like, but I don't feel like running. It's miserable if you got a lot of weight. Now, I do have some marathoning patients with obesity, but it's not common. And the last thing they want to do is go for a run. That's uncomfortable for them. So you get them strength training, and it's something they feel comfortable doing. Like, and to get discouraged by a doctor to do that, especially when there's great data for it, it's very frustrating. Yeah, thankfully there's a lot more data, and actually the guidelines say you try to strength train a couple days a week, so that's good. But yeah, it's still being pushed out there.
Yeah. That's okay. I think the new guard, I have hope there's so many great young doctors coming up that are fit themselves. I always say, that's a great parameter. Find a fit doctor. They usually end up getting it.
AI is going to take over anyway. Yeah. AI will tell everybody to lift weights. I'm pretty sure.
Isn't that crazy?
It is crazy.
I've been I use AI a lot, and I really like it. And I really think the humans who cannot figure out how to work with AI are going to be the ones left in the dust. It's not.
I love AI. I talk to it all day long, and try because I use Claude, ChatGPT, and Grok, and I cross-reference and then reference my other things and make sure that and it helps me learn it, and it's so smart, but it hallucinates sometimes. So then you cross-reference, but it's the future. I know it.
Yeah, yep. And I never in a million years thought that it would replace doctors first, but I think it's going to be the blue-collar guys that stay afloat, and I think the doctors are going to be, especially the mediocre ones, the ones that aren't staying with it, Yeah,
who the hell's the AI is not going to come fix my toilet?
Or my electricity. I know my husband's an electrician, so they're big blue collar family, and they're good. I think they're actually just going to make more and more money. I think the trades are going to get.
I agree. I think that's unless they get robots, I suppose, but that's future.
Oh yeah, but they're coming too, and I think they're coming in medicine. I just think about like radiologists and what an incredibly difficult job that is to hone that skill, and how many years it takes to be able to see those discrepancies on images, and to know that AI can see it like that. It's wild. So yes, I hope that, and you can't trade out bedside manner, good bedside manner, and just good heart to heart. But
we'll see.
Yeah.
We'll see. Some of these things are beating. I mean, and I could see it. I've talked to Claude and these things, and it's like, oh man, this thing's very like compassionate when talking to me. I'm like, oh man, this thing's better than me. I'm done. I'm done.
No, you're not. Okay, so we covered. I wanted to make sure we covered all the things. So strength training, you got to do it, guys. It's not the peptide causing you the muscle loss.
So we're publishing some case studies where we have a prospective trial, or I should say a prospective study, not a trial. We're not doing a randomized trial. We actually will be doing a randomized trial, but like we're showing minimal fat-free mass loss. So for people listening, you can follow my chief science officer, Dr. Grant Tinsley, who's a big-time body composition expert, but he goes into how DEXA scans don't look at muscle directly, but it's a fat-free mass loss. And when people lift weights and eat adequate amounts of protein, not even overdoing it, but lifting weights, it's minimal. It's minimal. It's 10% or less, or sometimes zero, or even they gain fat-free mass. It's amazing.
Yes, I'm with you. I heard you say somewhere, and I completely agree with you, that strength training may actually be more important than the protein
Yes.
intake.
Yes, by far. Yes.
Share some thoughts on that, because
Well,
I'm with
so,
you.
yeah, because you look, this is like kind of standard sports medicine literature where, the bodybuilders, the athletes. And when you look at that data, you need to send the signal to the muscle. You can give the muscle building blocks, but if you don't have the signal to build, it's not going to build anymore. It can maybe a little bit, but if you're not sending that signal to the muscle to grow, or even just stick around, it's gone. So it's magnitudes higher of importance. And if anybody wants, so people like Brad Schoenfeld, Stu Phillips, those guys are kind of pioneers in that stuff. But it actually crosses over to obesity with these medicines. Actually, I was at an obesity conference and we did a debate. I was going against a guy, John Jakisik, brilliant exercise researcher. And we had to pick sides of resistance training versus aerobic training when it comes to obesity. And back then it was 2022 or 2023. Yeah, 2022 it had to have been, or 2022 maybe. And I picked resistance training, of course. And I went through all of it. And back then, like these drugs were just kind of coming out and people weren't talking about as much. But I made the argument that look, these medicines will get people walking around and being physical activity. Nothing can replace resistance training. You just can't replace it with anything. You have to do it. You can't take more protein just to try to make up for it. It won't do it. You have to send the signal. And now there are actually review papers out that basically, I can tell some of these people are in the audience because I'm like, that was almost verbatim of what I said at the debate. And people were kind of like, they kind of agreed with me, but at the time, it wasn't, like you said, like even 10 years ago for you at these conferences, people were like, no, whatever, just do aerobic training. But now people are like, yeah, no, we don't have drugs yet. They're actually looking for drugs that try to spare muscle mass. And quite frankly, I don't think they're going to be super successful because you actually have to look at the functional component of it. Sure, we can make people, block their myostatin and all these different things that they're looking at and prevent them from losing muscle or maybe even make them gain muscle, but you actually still have to use it to make it functional.
Yes.
So I don't think anything's going to replace, not anytime soon, maybe in the future. I can't say never. Maybe there'll be some drug where it's going to make you super strong and jacked, beyond obviously some testosterone derivative of some sort without the metabolic effects. But
I don't think so, because you think about in the advancements in bone, we had Fosamax trying to replace bone, trying to grow good, healthy bone. It just makes chalky, powdery bone. And in the regenerative medicine space, we've had a multitude of things that they thought they could inject into or near, like, say, vertebrae that have been crushed to try to regenerate them. And it just causes all kinds of osseous outgrowths and problems. So what people don't get is that, like you said, you have to send the signal. It's this balance in the body. It's this orchestra. It's like the AMPK mTOR balancing act. It's the myostatin. It's all of these things that's a big lesson. But, and I don't want to, we don't need to get into it here, but it's this orchestrated balance. And if these are nudged appropriately through your nutrition, through your strength training, through all the GLP-1s, we can modulate it. And I think some people's systems just get whacked. And in that being completely whacked, that's why I say, if we're going to stimulate this side, if we're going to stimulate AMPK with a GLP-1, we have to stimulate mTOR to balance it out through going to the gym. Like, you have to go to the gym. You have to go to the gym. And yes, we got to hit our protein macros. I don't think they are as important as actually hitting the gym consistently and getting that signal to send consistently, right? And we don't want to overdrive any pathway with a medication too hard. That's why I think the people who are like hell-bent on the metformin for longevity and the people who are hell-bent on the rapamycin for longevity, it's just like, or you could just go to the gym consistently, get some sunlight, and
we're trying to take a shortcut. We're not talking about GLP-1s being a shortcut, but when it comes to exercise and building, I don't think there isn't a shortcut.
You got to send the signal. Like you said it beautifully. I think that's exactly it, because that signal it sets off a whole complicated orchestra in the body that makes things better.
That's
And
right.
without it, you don't get the signal and you don't get the better. And I do think strength is a superpower. And if you don't have strength and you don't know the value of strength and strength training, you don't appreciate it. So a lot of these doctors out there, they might go cycling. I can't tell you how many cyclists I treated in my practice because they'd have like bung knees or bum
Oh
backs.
gosh.
But they were all these guys in their 50s they would go ride 100 miles on a weekend
Mm.
or run 12, 15 miles a night, but they all had pot bellies and they all were sitting on the edge of diabetes. And I was
Yeah,
like,
it's kind of interesting.
yeah, super. I was like, well, eventually you will run yourself into low testosterone and diabetes if you don't balance things out right. So you got to go to the gym.
The other thing that I've noticed is that people have this number on the scale that they want to see because they think they're going to feel good about their body, and they get to it and they're like, you know what? I don't feel good about my body. I'm like, well, I think you're focusing on the number too much. What you really wanted to do was shape it in a certain way. And they're like, yeah, I think so. I'm like, and they kind of point out some people or whatever. I'm like, yeah, they're lifting weights, they're shaping it. And it's so whether it's for metabolic purposes or for aesthetic purposes, it's just so important. It's hard though. You got to start and figure it out and whatever, and try not to overdo it, annihilate your body and feel crappy and think of it as punishment. It's like, no, you got to learn to enjoy it and have good programming and all that.
I think it's the best money spent. I have had countless patients come to me and they want injections for their shoulders or for their knees. And I'm like, well, you have no muscle surrounding these joints and there's no activation of anything happening properly. So I'm going to send you to my favorite strength and conditioning coach. You're going to spend the money you would have spent in here, there, and call me in 90 days. And then
Yeah,
I would
that's right.
see them at the gym and they'd be like, hey, I feel great. How you doing? Their shoulder's
That's
good.
awesome.
But you put an ultrasound probe down and there's no muscle there. And the woman's complaining of, she's got limited range of motion. She's got pain. I'm like, yeah, we've got some frozen shoulder happening, but you're still never going to get through that. All the injections aside, you're never going to get through it if you don't start using it,
That's right.
Yeah. So use it or lose it. And I think that in harmony with a program that involves a GLP-1 agonist in there as part of a toolkit, I think it's just a really beautiful. I think the two together are so synergistic is what I'm trying to get at.
Perfect.
Yeah.
It's like peanut butter and chocolate.
That is yummy. Yes. Okay. Well, Dr. Spencer, I don't want to keep you all day. It's so fun to talk to you. And I'm glad we got to have this conversation. And I hope this has been eye-opening for my audience to hear. Obesity is a disease, you guys. It's for real. This is not a shortcoming of an individual. And where can they find you? Tell me more about Vineyard and what you're doing there.
Yeah. So Vineyard is basically a direct care model for online obesity and metabolic care. We remove all the barriers between the doctor and the patient. You also get your own dietitian. Our dietitians lift weights, by the way. They're very they're GLP-1 expert dietitians, but they lift weights. We have strength coaches, community group events. We go much more beyond the GLP-1. That's what we focus on because that's what people want. But side effect management, lab cardiometabolic management. I'm a lipidologist, so we do a lot of lipids and that type of thing. Even things like hair loss. You need some minoxidil to help with that. That all sorts of stuff to basically really facilitate and help people. But the big thing is it's a direct care model. We have small patient panels so that you get to talk directly to the doctor, and as opposed to some team member that then relays and you play this game of telephone. So that's joinvineyard.com. That's my new online clinic. And then Instagram, you can see me make funny memes and stuff there. I'm on Threads and Twitter. Threads, I just basically talk crap to people all the time. I basically respond. It's such a weird platform, but I'm on TikTok as well. I'm all over the place. We have a podcast called Docs Who Lift with me and my brother, and we just kind of banter back and forth about stuff and promote actually exercise, literally lifting weights as medicine, and try to promote the idea of lifting weights really for purposes of getting healthier.
It's a great podcast. I think I heard Grant Tinsley on there. I think,
Yeah.
did you have him on recently about the muscle loss, the lean mass, and he broke it down really granularly.
But he's much more of an expert in that realm than I am. So if you ever want to listen, he'll go into detail about how DEXA scans and how the compartments work and how how they test. It's pretty cool.
Yeah, it's good stuff. Okay, well, I will make sure everything's in the show notes for everybody to come follow you and find you. I love your Instagram. That's where I follow you most. And you guys, he's a wealth of information, and just you're just a level head in this scene. And I applaud you because you get a lot of pushback, I'm sure, every day. And this conversation is really polarizing for people for some odd reason that I think.
Oh yeah. They think I'm paid by Eli Lilly and Novo. I'm like, no, I don't pay. I purposely do not take money from them just to be able to say this. My brother and I were just talking, like, maybe we should take it. Do people care? I'm like, I like to just be all, holier than thou and be like, nope, I don't take money. See, I don't take money, but
I get accused of it too. And I'm like, honey, they deplatform. I'm pretty sure Eli Lilly deplatformed me at $232,000. I'm not thinking I'm getting any checks I haven't seen any checks.
They're not coming in.
They're coming in. So we're just trying to talk about this because we actually believe in it, and that it's in our heart. So anyway, so fun to connect. Thank you for being here and sharing your wisdom with us. Yes, thank you. Thanks for listening to the Dr. Tina Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guild. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.